Welcome everyone to Mayo Clinic Q&A. I'm Dr. Helena Gazelka, and we're recording this podcast on November the 23rd, 2020. It's Thanksgiving week, and this year celebrating is going to look very different for families all across the country. As the coronavirus outbreak worsens, the Centers for Disease Control and Prevention is now recommending no travel this Thanksgiving and asks Americans to stay home and celebrate with only their immediate family. Well, here to discuss this with us today is one of our favorite COVID-19 experts, Dr. Greg Poland, virologist, an infectious disease expert, and vaccine expert at the Mayo Clinic. Welcome to our regular Monday morning check-in. I know that you told your wife it was going to be a slow news week for you, but it sounds like that might not be true.
It's turning out to not be.
Well, Greg, since we opened with it, let's start with Thanksgiving. What do you think of the CDC recommendations for travel during Thanksgiving, and how will you and your family be managing this?
Yeah, I think those recommendations are spot on. This is something that CDC has done a really good job with. Since 6 days ago, we've gone up 1 million. That is just unbelievable. 6-day period, adding 1 million cases. We're having in Minnesota about 50 people a day die of COVID. And this is being surged or fueled by the deceptively safe sense that if I get together with my small group of friends, with my family, that nothing will happen. And that simply isn't true. What we're finding, even in our own community at Mayo Clinic, is that people are getting infected outside of work, in these small family and friend groups. And that's exactly what Thanksgiving is. There was a record amount of travel this past weekend since the pandemic started. And this is playing into exactly what we've talked about in past weeks. This will further fuel an already exponential pandemic all the way through the new year. And that's just a shame. This is a year to celebrate Thanksgiving, but by a distance.
So tell us about your plans, Greg, for Thanksgiving.
So what we're going to do is set up a table that will include place settings for our kids who will not be traveling to come and see us. And we're going to set up Zoom. We're going to have a Zoom Thanksgiving. First time we've done that, but we've actually had to do it once before when my son was deployed overseas. So we're used to doing that, and I think we all feel really good that we're taking care and loving one another by doing that. I've insisted my wife make the standard Thanksgiving meal, and we mailed off boxes of Thanksgiving goodies to the kids, and that's how we're going to do it and be safe.
Well, I think that I had mentioned a couple of weeks ago that we typically have a large family gathering for Thanksgiving in Wisconsin, and we won't be attending this year. We will be also celebrating at home with only the immediate family with whom we are in close contact here celebrating with us. And we'll also be using some Zoom or FaceTime to get in contact with family members who can't be here.
You know, that's the right thing to do, and it's the unselfish thing to do. Traveling and gathering together, unfortunately, has to be characterized as something, maybe a popular way of saying this would be this way. It's not about you in a pandemic. It's about us. And you and I have obligations to our patients, to our families, to our friends and community. And that has to be the outlook, I think, for this unusual year.
What's amazing, Greg, is that even short of travel, with the numbers blossoming the way they are, people are still grappling with doing the right thing. I don't know if you saw in the news, but a CEO of a major healthcare organization in the Midwest stated that he had had COVID and he was not going to wear a mask. And I thought, wow, that just flies in the face of science, and it really is astounding.
There are so many misperceptions. There's so much selfishness. There's so little regard for our fellow citizens that is driving this, and very much an anti-science sort of feeling out there. I've had the same thing. I was at a store and I said, hey, keep yourself safe, wear a mask. and very aggressively said, I'm not going to wear a mask. You can't make me wear a mask. I mean, you think, what kind of attitude is this? You know, how many people have to die? We are now at the stage where about 1 out of every 1,300 Americans has died of COVID. And those numbers, mark my words, this is November 23rd. I will predict to you that we will get up past another 100,000 deaths before this is over because of this kind of thing. And every one of those people who die is somebody's son, daughter, grandmother, grandfather, parent. It's just a shame. It breaks my heart as a physician to see this.
It really is. And even just in a humanitarian line of thought, I think the holidays we always think of, no matter what our religious proclivities or ethnicity, whatever, but there are holidays that we're all celebrating, that we think about peace on earth and what gift we can give to our fellow mankind. But what could be better than to take care of each other these holidays?
Really well said. The gift of health and the gift of caring and of love for neighbor.
Well, Greg, we're going to move on a little bit. We have a couple of other topics I want to get to today. And the first one is some of the new treatment that is being used for COVID-19. I'm thinking particularly of monoclonal antibodies. We've had them available here at some of our, and in some of our institutions at Mayo. I wonder if you tell us a little about that.
Yeah, this is really exciting news because we're making advances not only in the vaccine department, but in the therapeutic department. In other words, what happens when somebody who's high risk gets infected? Well, we've now got 2 different monoclonal antibodies that we can use. These appear to be safe. The one downside right now is that they have to be infused intravenously. And they are not for people that are sick enough that they're in the hospital or on oxygen. Now, this provides somewhat of a logistical barrier, even though this is progress. You have to sort of figure out who's at high risk of progression and get to them and treat them with monoclonal antibodies before the infection gets to the point that they need to be hospitalized or on oxygen. An easy way to think of it is this way. You know, water to put out a fire works best when the fire is small. Once the fire has engulfed the entire building, water is much less likely to help. And the same is true with these monoclonal antibodies. We want to fight that fire early on for people who have gotten infected.
And I think that here, Greg, the state of Minnesota and Mayo Clinic, we're following primarily the CDC guidelines for who is to receive these monoclonal antibodies. You mentioned patients who are not hospitalized, and I'm thinking of some of the other requirements, one being age over 65, I think, patients who have had COPD, obesity. I can't remember the others. What are some of the other?
No, you're really pointing out, Helena, and that's exactly right. It's the subgroup of people who would get infected that are high enough risk that we're worried about them progressing to the need of oxygen or hospitalization. So, you think about it with influenza, for example, when somebody gets infected with that, we try to treat them within 48 hours of developing any symptoms. And I think that same principle is going to hold true with monoclonal antibodies and COVID.
Now we'll go on from treatment to prevention, which is coming right along. There seems to be news about this almost every day. It's very exciting. Would you tell us a little bit about what's happening with vaccines as far as research, and also what's happening with the vaccines who've already released some of their data? As
we know from the last 2 weeks, both of the mRNA vaccines, the Moderna and the Pfizer vaccines, have been shown to be about 95% effective. This is stunning news in the world of vaccinology and public health. We really thought these were going to come in around 50 to maybe 70% effective. 95% effective is essentially as good as any vaccine that's ever been developed. Now, this morning, what we heard is that one of the first adenovirus vectored vaccines, and I'll explain that in a minute, made by AstraZeneca, has also shown efficacy. Now, what's a little complicated about this and highly likely to be misinterpreted is this. They had one arm of the study where people got a half dose as their first dose, a full dose as their second dose. They had over 90% of efficacy. The second arm of the study was people got a full dose for the first dose and a full dose for the second. And that showed about 60% efficacy, not expected. I think it's likely to be explained by the fact that these are a viral vector, meaning a weakened or non-replicative common cold virus that the spike protein gene has been inserted into. And then this administered to a human being. And what's happening is that the body makes antibody against that viral carrier. Yes, against the spike protein also, but also the virus used to carry that spike protein into our cells. And I suspect that's why the half dose as a first dose worked much better than a full dose as the first dose, because you're not developing that level of antibody. Then you come in and boost it with the second dose with a full dose. There's some reactogenicity to the adenovirus vectored vaccines, but very acceptable. So what that tells us is that we have 3 strong vaccine candidates now that will be moving toward FDA approval and emergency use authorization. That'll be followed by another adenovirus vectored vaccine, and followed very quickly after that with yet a third type of vaccine, which is a protein subunit vaccine. So we are doing far better than expected. It raises the issue, though, with the kind of scientific misinterpretation and rejection of science that we're seeing. The polls are showing that maybe 30 to 40% of people will reject these vaccines, which has the paradoxical effect. This is what gets me. The people that don't want to wear masks, that don't want to take precautions, that don't want to take a vaccine, they are prolonging the pandemic. They're making the pain worse, which is the thing they don't want to do. We can't mandate that people take a vaccine. It's their right not to take one. But who covers those healthcare costs when they get sick?
Greg, I'm really glad that you brought that up, because I'm a scientist and I work obviously amongst scientists. And even in our physician group, we've been talking, there's this conversation going on, will you take the vaccine if Mayo gets it, will you? And I think that number of 95%, you said, it's fairly astounding. It's better than what's been created in the past. I think there's this feeling of suspicion about that, perhaps amongst some groups, and concern that, well, how do we know that next year at this time we're not going to have some awful side effect or something from those vaccines that were pushed out so rapidly at us? Can you say anything to kind of quell those fears or help us grapple with those issues?
Absolutely. And those are legitimate questions. They really are. This has been a very fast development. So what would make me feel comfortable about it? Number one, the side effects that we see, any serious side effects that we see from vaccines, happen within hours to days to at most 6 weeks. So this is safety data that these vaccines will not be released until we have safety data for at least 2 months time period. We've never really seen side effects in a vaccine past that time point. And of course, as this progresses, every week we add another week of safety data among these tens of thousands of people. The second thing is the process that this will go through. This will not be politicalized. That will not happen. And the reason I say that is that all eyes are on this. I mean, I present the truth as transparently as I know it. My eyes and a bunch of other vaccinologists have our eyes on this. If I see a foul play, I'm going to raise the red flag right away. I mean, for everybody that can hear my voice, know that. What's going to happen is that these data will go the 8th, 9th, and 10th to the VRBPAC. That's a vaccine advisory committee of outside experts to the FDA. I've sat on that committee, so I know how it works. And they will look at these data and they will make a recommendation to FDA. FDA will take that under advice. And then if they approve it, let's say for emergency use authorization, it will go that next day to the CDC and another advisory committee called the Advisory Committee on Immunization Practices. I have sat on that committee. It's another separate group of outside experts. So nobody's going to get a vaccine until it goes through that process. And I think that process we can rest assured in that it is a high fidelity, high science expert committees that will look at these data. The other thing is that there are a number of what are called active and passive safety surveillance mechanisms being put into place, so that as we get to hundreds of thousands and millions of people who've taken the vaccine, if any subgroup of people start to develop any hint of a safety issue, it will be noticed and evaluated right away. I mean, there has never been the focus on vaccine development and safety in my entire 40-year career than what I have seen on this. And that makes me rest easy at night.
It reminds me of what I often tell my patients in the clinic, that I understand that trust is difficult sometimes. My patients rely on me as an anesthesiologist and a pain physician to know what I'm doing and to make recommendations soundly for them.
Absolutely.
I liken it to them to, I don't know anything about auto mechanics. And so when I take my car in to be fixed, I have to trust the person I'm taking it to, that number one, they know what they're doing. Number two, they're going to tell me the truth, and they're going to treat me fairly. And so I think that's really helpful what you said.
A civil society only works when there are high levels of trust. And, that's not to say the point that does keep you awake sometimes at night is the unknown unknowns, right? But when there are mechanisms put into place to detect those in a setting, this isn't the flu, this is COVID-19, in a setting where we have seen over 250,000 Americans die from this infection, and many more be sickened, and many more left with chronic medical problems even after they've recovered. I think it's justified to move quickly with a pledge to the American public that nothing will be spared in looking for any kind of safety signal that is unexpected.
I think the next natural question would be then, how do you do this? I cannot imagine the undertaking to immunize on this mass proportion. And I'm wondering, number one, who gets to decide that? Do the drug companies decide who gets their drug? Does the FDA? And then how do you see that working and being triaged?
Yeah, this is another very good question, Helena, and you always ask good questions. This is something that's been looked at very carefully. I published a paper about this, and the idea here, I think, is going to be to fuse egalitarian and utilitarian ethics. In other words, utilitarian is we've got to protect the healthcare workers that are on the front line. Then we've got to protect the high-risk people and essential workers. But at the same time, there are population groups, we've seen this, the elderly, some of our minority communities that are suffering a disproportionate burden of disease. So they have to also be among the first that are eligible to get the vaccine. You and I don't decide that. What has happened is that two independent expert groups have weighed in on this: the National Academies of Medicine and the ACIP, the Advisory Committee on Immunization Practices that I mentioned. Both of them have come up with a schema that matches very, very well together. So what will happen is when a vaccine is approved, it will be shipped out to states. States will distribute it across pharmacies, medical institutions, et cetera. And then vaccines will be administered according to these guidelines. So if I'm a 30-year-old healthy individual, I'm not going to get vaccine this year unless I'm a healthcare worker or unless I have medical problems that put me at very high risk. So what we're going to see is sometime before the end of December, stretching out. Remember, we got 350 million people in the US, and this requires 2 doses a month apart, stretching out through the winter and spring. And I think by then there'll be enough doses that will cover everybody. So it is still true that while we're doing this, people will need to respect mask wearing and social distancing in order to keep everybody safe.
So, Greg, just to clarify, do you think that our average listener, who's a healthy individual, maybe doesn't fall into any of those high-risk categories or healthcare worker categories, next spring would be the time when they might begin to see availability?
Yeah, I think actually as early as the first quarter of 2021, stretching into the second quarter of 2021. I mean, this is all hands on deck. People have worked unbelievable hours to set up systems. The military is going to be involved in transporting, not administering, but transporting vaccine so that within 24 hours, this is unprecedented, within 24 hours of approval, every state will have vaccine. I mean, this is an incredible, this is a wartime mobilization is the way I would put it.
Well, and that's amazing given what we know about how those vaccines have to be kept carefully.
Yes.
And
yes.
temperature controlled, et cetera. That's really amazing.
Yeah. So this is all, we have not had a lot of positive news to talk about over the months. And so you can probably detect the excitement in my voice to see that we're going to have vaccines. We're going to have therapies that will protect lives. I mean, you and I, without even talking about it, Helena, know what it means to save a life and that life go on for years and years. And that's what we are on the verge of doing in a few short months, an unprecedented historical achievement. People are going to live that would have died.
No, Greg, that is reason to hope and to be thankful this Thanksgiving.
Indeed, indeed.
Any last words of wisdom for us as we go into a holiday week?
I really would plead as a physician with whatever trust I hope we've brought to bear over these months that we've done these, is that you please reconsider traveling and who you get together with these Thanksgiving and Christmas holidays. This is a time to keep everybody safe. The gift of life is incalculable in value. We have seen how small group gatherings, small weddings have led to people being admitted to the ICU and even dying. And ask yourself the question, is it worth that?
Yeah, those are sobering words, Greg. And I think we also just want to extend to our listeners and our watchers that we understand this is really difficult. This isn't just Thanksgiving. This is life and death. For some people are unable to participate with their family members at very important times in their life. And it really is heartbreaking.
The other thing maybe to add, and this is not to scare people, but for people to have an understanding of what happens when a virus like this, an RNA virus, spreads unchecked through the human population. We are now starting to see additional viral mutations occurring. It has happened between mink and humans over in Europe. In Europe, we're starting to see now 40 to 70% of the infections occurring are with yet a new variant of the virus. So this is not something to play with. This is something to take very, very seriously. We are all better off if this virus infects far fewer people because it means less of a chance to mutate. And that's what's going to keep us safe. Hands, face, and space is the way to think about it.
Thanks so much, Greg. I'm thankful for you this Thanksgiving.
Well, and I'm thankful for you and for the producers of this. This has really been a team effort, and I hope with joy, with celebration, we're going to be able to talk about the release of these vaccines and start seeing the infection rate plummet.
Our thanks to Mayo Clinic infectious disease, virology, and vaccine expert, Dr. Greg Poland, for being with us again today to give us our updates. We're thankful for you too, for listening in, for joining in with us as we learn more each week. We wish you a wonderful Thanksgiving and a terrific day today. Thank you.
Be safe.
Mayo Clinic Q&A is a production of the Mayo Clinic News Network and is available wherever you get and subscribe to your favorite podcasts. To see a list of all Mayo Clinic podcasts, visit newsnetwork.mayoclinic.org. Then click on podcasts. Thanks for listening and be well.